The DRAFO can create some pretty unbelievable outcomes, but how do we really know, and what are we comparing them to? Our industry is changing. Outcomes are coming. We need to prove what we do. You ask why? Hospital contracts are now starting to require outcomes measurements. Insurance contracts, state and federal mandates, Medicare. Many medical practitioners have become accustomed to the necessity of providing some justification for their treatments, prescriptions, and procedures for many years. Patient care providers in our field need to understand the importance for outcomes and measures to justify and maintain current reimbursement levels in our industry. We've included some practical outcome measures for you to get your feet wet and to get started with outcomes measurement, which is coming down the pike for us. There are 10 measures that you can easily do. Today we've included 2, the 10-meter walk test and the ankle arthritis scale. The time required to do these is 10 seconds to 20 minutes, and the items you need is a stopwatch, a tape measure, tape, and a copy machine. The first of these outcome measures is the 10-meter walk test. The 10-meter walk test is performed with a flying start. That is, while the subject walks about 14 meters, the time is measured for walking the intermediate 10. The 10-meter walk test has been proven valid and reliable for chronic stroke, neurologic impairment, spinal cord injury, and cerebral palsy. An example of the 10-meter walk test validity is the study Wang did in 2005. He tested CVA patients for short duration versus long duration, with and without an off-the-shelf AFO. The short duration showed that there was almost a 3-second improvement with the orthosis, and the long duration showed at least a 2-second improvement, thus concluding that the use of an orthosis was indicated. Interestingly enough, the 6-meter walk test and the 10-meter walk test, in a study done by Van Heedel in 2006 on recovering spinal cord injuries, found that compared to other more complex instruments, both of these outcome measurements were more responsive and demonstrated less of a ceiling effect. The ankle arthritis scale, developed by Domzik in 1998, it's disease-specific to ankle osteoarthritis. It's a visual analog scale, and you have 2 categories: one, pain, which the patient fills out with 9 items, and disability, which the patient also fills out with 9 items. It has been proven valid and reliable. This is the example of the disability scale that the patient fills out. The ankle arthritis scale utilizes a 100 millimeter line left to right. The patient puts a hash mark on that line to denote the level of pain or disability. Increased scores equals increased pain and disability. Some subscale scores divided by items gives you your result. Non-applicable items are dropped. Used in 8 peer-reviewed publications for surgical techniques, injections, and distractions, the ankle arthritis scale has proved valid and reliable. Thank you for your interest in the DRAFO system. This process, though very simple, is a completely different approach than how we were trained. With use, you will find that your patient outcomes improve, sometimes dramatically. Please feel free to utilize us as your resource as we move forward together. Thank you.